One of the TCRs that was identified targeted a 9-mer peptide that overlapped G12D, and the other was a 10-mer peptide. And interestingly, the 9-mer peptide was CD8 co-receptor independent, meaning that we could transduce that TCR into both CD4 and CD8 T cells and use that for other patients. The 10-mer TCR was CD8 co-receptor dependent, so when we transduce that TCR, we need to sort for the CD8s only. And I guess that clinical starting point in a patient that had eradicated their tumor with this T cell receptor was a proof of concept that targeting a driver mutation in a cancer could eradicate that cancer. And then we asked whether we could target the G12D mutation which is broadly found in many different cancers and is essential for the growth and persistence of the cancer cells. If we could target that in other patients by taking that TCR and retrovirally transducing it into T cells from other cancer patients. The one caveat is that the restriction element is HLA-C0802, and so we've had to match other patients that have the KRAS G12D mutation as a driver in their cancer with their HLA type, and it must be C0802. And so in today's presentation, we discussed 2 patients with pancreas cancer who received both these TCRs that were retrovirally transduced into their own T cells that we had obtained through leukapheresis. And one of the patients had a response and the other patient did not. And so the gist of the presentation was comparing what we know at this point about the patient that responded and in contrast the patient that did not.